Good. So Tiggy and I are hosting this session, but we want it to be very open. I think there are a lot of people who have done, I see already there are a lot of people who have done a lot more work in this than we have. And so we're hoping that this can be really a good place for people to talk about what kind of work is going on and what kinds of questions they either are working on or might be moving forward with. As well as about issues, I think, around data. So just to get us started here. So I think the term vulnerable populations, I think so much of what we've talked about so far with respect to this pandemic is really about how to identify and understand who is the most vulnerable. And I think that does seem to be changing shape and becoming more clear with time. So when we were thinking about what would be useful for discussion here, we were trying to decide what we mean by the term vulnerable populations. I think that it's clear already that this is unfolding against a backdrop of dramatic economic and healthcare system inequality in the US and as well as around the world. I think in some ways, the inequalities of this outbreak have been obvious from the start. It's been very clear, just as we saw the rollout of testing access in this country, that there were some people who had a very easy time getting access to this, and then most people really struggled and continue to struggle. And this, a lot of the both health-related and structural factors that are leading to increased vulnerability are tied to race as well as socioeconomic status in ways that are really hard to disentangle. So I think we also were thinking about this in a couple different ways. There are reasons that people may be more vulnerable to infection. So I think a couple of important ways are employment. So the people who are doing essential work, who are, well, many of us are able to still work from our homes and be more protected. These people are at higher risk and often are in jobs that are predominantly or disproportionately done by Black and Latino people in the US. Also, the ability to work from home is maybe even different from that because there are a lot of people who are now facing unemployment, and this threatens their ability to isolate successfully. This is also tied to housing, so what kind of housing you live in, whether or not you do have housing, but whether or not you are a homeowner or are renting or living in a more crowded area. And then with respect to crowding, there are very high risk populations who are living in high density settings. So people who are incarcerated, people in detention centers, which has an even more, we think, burden of limited access to supplies that could keep them safe and sanitary. And then, of course, nursing homes and assisted living facilities. So these are all, I think these are overlapping with higher risk of morbidity and mortality, which Tiggy is going to talk about. But these are some of the things that we've been thinking about.
Right, so yeah, in addition to some of the risk factors that Inga just mentioned, there are also critical vulnerabilities we know shape the severity of disease and result in lower recovery rates and higher disease-induced mortality rates. These drivers can be broadly categorized as impaired immune systems due to chronic health conditions and age, environmental risks like pollution, social isolation, and constrained access to care, which limits testing and treatment. And so we see similar challenges on the next slide. Thanks. You see similar challenges confronting overlooked and neglected populations worldwide, where, for example, it was recently reported in the, I'm sorry, I'm not going to pronounce this properly, but in the Moki Hatetema community in the Amazon, Brazil, there was an imported case. and there are limited resources in place, structures in place to combat potential outbreak in these settings. So that's like a major concern that we need to address. And then in a lot of these settings, there are also compounding issues in addition to COVID that these populations are facing, other infectious disease threats, as well as recently climate-related catastrophes like the locust droughts that are, the locust outbreaks that are occurring in 3 countries in East Africa. So there's a whole backdrop of concerns and issues that are important to take into account. Okay, so next. Right, so now we're just gonna open it to discussion because we just love to hear from all of you about key issues and information that we need to address now, and what are potential directions that we could take with future research on this, or what are key questions that need to be addressed at this stage with research. And then also keeping in mind limited data availability in some of these contexts. So yeah, just opening up. So feel free to chime in, unmute yourself and chime in whenever you would like to.
I'm happy to chime in. This is Nancy Krieger.
Okay, great.
And first, I just want to say, I mean, it's wonderful that you have this breakout session, and it's also wonderful that this meeting has been convened this way to bring people together while we are all, and you particularly, in the thick of doing this kind of work. But I would like to make a point and then also ask a question. And the point is that, and this is true not just in the literature on COVID-19, I think what we're seeing with COVID-19 as usual is that it's bringing a spotlight on many issues that already exist, whether that's societally or within the research itself. One is this framing of so-called vulnerable populations, which always puts the onus basically on the people that are worst off because of injustice. And it leaves out of the picture the frame of what the injustice is. And I think that, and you see this in social epidemiology more generally, you see it in mainstream epidemiology too. So this is not unique to COVID-19, but because I think the work is moving so quickly in COVID-19 and it's making these inequities that have been there and been effectively acceptable and or ignored by people with power and people with resources, that this is a chance to sort of frame it differently, more effectively with all the work that's going on now around structural racism, with the work that's challenging the neocolonialism and all the rest, to be actually explicit. And that's not being ideological, that's actually being scientifically accurate. And so I think pushing on even the framing of vulnerable to talking about who is subjected to injustice and what does that have to do with the health risks of both exposure, but also given exposure, likelihood of illness and death, I think is just a really important point. And then the second part, so it's also not talking about factors like quote unquote race, but talking explicitly about racism. There was just an excellent piece that was in, I believe, the Boston Globe 2 days ago with the title that race is not a risk factor, living in a racist society is. That just makes it that this is where, you know, the journalists are out ahead now. And I think this is a time to really make that difference. And then what it means for the variables, it means whenever possible, connecting whatever is available on, for example, the markers, whether it's race, ethnicity in the United States context, indigenous status in the US and in many other country contexts, Roma, whatever, to economic variables. And in the US, it's outrageous that the data have yet to be properly produced around race ethnicity, that it could be acceptable that there's so much missing, but also that it's completely severed from any economic data, not even educational level, which is in the death certificate. So I just think that making the data speak to what the root causes are is really going to be important. And that has to be baked into the surveillance systems. And if it's not in the surveillance systems, it has to be put into it. And if it is in the surveillance systems, it has to be reported.
I think so those are all I think, really important points. I also thought that, for example, the paper that you wrote, Nancy, with Matt King and Taylor and Rebecca, who are, I think, not here, but this is obviously, a lot of this research is being led by infectious disease epidemiologists, and many of us, I think, do not have the same like understanding of how to frame this. It seems like a really good opportunity and absolutely necessary for there to be collaboration between people who are focused on infectious disease epi and people who have more experience in social epi, because that does seem like a place where there's already being information and research being left out.
I agree.
Are there people here who are working on projects or doing research that is relevant to this discussion session that would be like useful, or that you would be interested in sharing?
Hi, this is Rohan Kazanchi. I'm over at the University of Nebraska. I'm actually a medical student and also a public health student. And I've been working with a pretty interdisciplinary team, trying to look at the data that we have now in terms of COVID outcomes, mapping it to, as Dr. Krieger kind of alluded to, some county level risk factors that are available in publicly available data sets, and perhaps even looking at similar data sets to the preprint that was recently published. And one of the challenges that we've been thinking about is how we can attribute outcomes to structural risk factors when the level of granularity of the data available is currently only on the county level. So I think seeing one of the questions on the board right now about data availability, one of the challenges that we've been thinking about is that when we think about social vulnerability, to use that term that we've presented this discussion around, it's challenging to do that at the county level. It would be easier to draw perhaps more conclusive causal pathways from something that's more along the lines of zip level data or patient level data, which is not being published on a national level. We've only seen race and ethnicity reported, on the city and state level at this point. And I think that's been a challenge for our team to think through based on available data.
I mean, I just want to jump in again, Nancy Krieger as a social epidemiologist. There's a lot of contextual data at the county level, but also you want to think about what the relevant levels of governance are. Counties can sometimes be they're not just a geographic unit, there also can be a unit of governance, but also what the state policies are. And it depends if you're trying to do analyses just within one state versus you're doing across state comparisons, and there are model designs, fixed state effects, you can put in the different policies that states are doing around when they said people should stay at home or not, et cetera, et cetera. But there's a welter of variables at the county level per the paper that I was brought into, but also others as well. And I mean, it's easy enough to list a compendium of variables, because you want to be able to link individual people to their context, but you absolutely need contextual data to make that context clear, and that will not be data gathered just at the individual level. So ideally, you want to be able to geocode an individual's residential address to precision and link, if possible, to census tract data, as well as whatever the relevant unit of governance is, city and or county, as well as to state. I mean, there's lots more to say, but there's a lot of variables, and there's a lot of work done in the literature now on getting at two different kinds of measures of structural racism at the county or other levels. One are measures that are actually what you consider to be the direct measure. You're actually capturing a policy that is directly or implicitly, for example, some of the ways to get around voting restrictions without naming race, but with racist intent. But those are actual policies. Those are not. And then there are others that are being called measures of structural racism, which are just more or less area-based measures of differences between groups at that level on key metrics like employment or something like that. If you want a list of the kinds of studies that do this and the kinds of variables available, I have a paper that got published just now in the Annual Review of Public Health. It's free, it's an open access paper, it's on measures of discrimination, and it goes through the kinds of measures that people are looking at different levels and also in relation to structural racism, but it also looks at it in relation to, which is relevant here, around gender, gender binarism, class, et cetera. So, I mean, just to say there's a lot of work on the social epi side and in the social science side on a ton of things you can look at the county and state level that are very useful.
Oh, yeah, thank you for sharing that, Dr. Krieger. I wonder if there are variables, specific types of variables that can serve as proxies or inform our understanding of inequalities in testing rates, for example, when this data is not made explicitly directly available by existing policies. Yeah, this is just like a challenge that I've been thinking through recently, because we know the disparities in severity of COVID have been made pretty clear through data across several states, but there's still a lot of information being missed on testing rates and access to testing. So I wonder if given the data that we have, if there are other factors we can account for to potentially infer these inequalities in testing rates.
This is Nancy Krieger jumping in again from a narrow US context, but I mean, there's certainly medically underserved areas. There's definitions of that. You can find those. Those are developed through HCQR. And then you can also look, you can do things about looking at where people are in relation, what's happening with community health centers. You can look at also look at what the state mandates are about where they're putting testing. And I mean, there's a lot of different ways I can imagine to go at that. I mean, there's the very basic stuff that people started doing with the New York City maps to look at, you know, what the zip code income is in relation to but there's not data on who got tested. I mean, you don't have a good denominator. And that's not going to be something that comes out of an ancillary data source.
Hi, this is Henry Kahn in Atlanta, where I've been on the faculty at Emory University Medical School and worked at CDC for many years. I'm very grateful to the Center for Communicable Disease Dynamics and to Dr. Krieger, Professor Krieger, for clarifying in so many ways the research that has already been done. It's not a surprise that we have vulnerable populations, but we who work in public health have a duty to also be advocates. And I'm wondering why we limit our questions in this particular breakout session to the directions we need to go with future research. I'm all in favor of future research and refining the granularity, among other things, giving access to communities that have not previously performed their own research. But why aren't we stepping up to the obvious factors upon which we could demand intervention? It's not just democratic things like better elections. It's not just things like letting people out of incarcerated circumstances. But what about the peculiar inability of our society to generate access through universal health insurance? The cost of our medical care. These are things which has now made it into the mainstream thanks to a presidential campaign in the last 2 years with at least one candidate, two, speaking up adequately on this, and now the COVID-19 disaster. I think these are ripe for advocacy, and who better to advocate than distinguished institutions of research where the data are already sufficient to say we need a universal healthcare system that would get many of the barriers out of the way toward getting our better science and better outcomes in healthcare.
Yeah, thank you so much. We completely agree with the fact that we should be serving like a dual role of advocates, researchers, and like drawing on the research so far to potentially shed light to these issues as we advocate. And so I guess leading, another question we had was like, how do we negotiate this balance, because sometimes it can be a tricky balance between our role as researchers and just like sharing facts, this is what we've learned from researchers, and kind of having a more, using that language of advocacy more so in communicating these issues.
Well, let me respond to that delicate balance question. The delicate balance is not new, it's just wrong. uh, we've allowed ourselves to be suppressed by an unspoken dependence on national funding, corporate funding. It's fortunate the CCDD now has another source of funding, which is apparently wonderful and terrific. And I thank the donors who've made that possible. But I think it's time for those of us who are privileged with salary jobs or pensions and time to stand up and ask our governments at various levels to speak up. I'm working in Atlanta on a campaign to get our city council to speak up about wanting to see innovations in the state of Georgia and ultimately the nation in how we provide healthcare funding. I have nothing to lose as a retiree, but those of you who will eventually someday be retirees too could find ways to say, we need to articulate our expectations based on ample evidence now so clear that we have a peculiar indifference to what the real problem is. I use the phrase, peculiar indifference. It's not mine. It belongs to W.E. Du Bois, who wrote it in 1899 in his chapter on the health of Black people in the Philadelphia Negro. He said, what's new is not that the Black population does so poorly in mortality and in the diseases of the time, consumption and so forth, but what's new is the ability to talk about it. And yet there's a peculiar indifference of the political animal to acknowledge what's there. We're in a position to speak to that peculiar indifference and say, why are we not doing more as advocates? I'll back out. I'd love to hear other people's ideas of how they, in their communities and intellectual settings, could frame advocacy positions that need to be heard in addition to the excellent research I'm already learning today.
If other people have, I think, thoughts in response to that, I definitely am interested in hearing them. So please feel free to follow me with an non sequitur or to raise your hand or something so I can see who you are. But one of the things that I've been talking a lot with Tiggy about over the past couple of weeks has been that we are interested in trying to advocate for, and this is something that, I mean, we didn't come up with, other people have been talking about this, but for ICE to stop further detentions and to release people from immigrant detention centers, because we know that these are places that are at maybe at an incredibly high risk for outbreak, and because of some of the factors that we know. There are issues with overcrowding and lack of sanitation and other things like this. We've seen that there have been outbreaks of other infectious diseases in the past, and that people have incredibly limited access to healthcare. So really, it's there are already pre-existing human rights violations happening in these places, and we've been trying to, I think, figure out how do we join what we know epidemiologically about the risk factors in order to say something that is new and compelling, that could actually be more effective than what we see already, which is, I think, mostly based on anecdote and, I think, pleas from people who are working in these settings. So I think this is like an open question that we have right now. If people have ideas or are interested in talking about it, I think that would be really helpful, because we are sort of trying to figure out where to go and how to move forward with it.
Yeah, and to add to this, we're kind of also struggling with how do we communicate models and their potential uncertainties that shed insights on these issues. Yeah. We'd really love your feedback on this.
Hi, it's Tori Cowger. I'm a graduate student at HSPH, and I am doing some work on incarceration, not specifically related to ICE detention facilities, but jails and prisons specifically. And they are a unique problem, but I think there are a couple things that we can do immediately as scientists to help. And the first, I think, is partnering with institutions that are like legal institutions, activist institutions that are already doing this work and were doing this work before. But giving the voice of an epidemiologist to those organizations to help them kind of compile a data-driven argument, even if it's not a perfect study, but pulling from the past what we know about like TB epidemics in prisons, et cetera, to help them make a compelling case from a public health perspective, I think is something that we can give voice to organizations and activists that are already doing the work. And because we're epidemiologists and people know what that word means, and they value that opinion, that can give more credence to the urgency and can kind of round out other arguments. That's just kind of one way that we have been working to try to get some of this done quickly.
Thank you, Tori. I think that's really smart and helpful. I would love to talk to you more about it later.
Hi, Inga, this is Nick. We spoke yesterday. As a part-time student, I work for a financial firm. So I have a comment and a question from the practical side, because I don't see myself as a researcher. I'm more of a practitioner. So I'm leading a team. Basically, we have a lot of customers who are vulnerable population. And I'm leading a team internally. We're trying to figure out how we can care and service those clients potentially better. And two populations of interest are, one being the senior people, senior citizens who currently live in senior communities. The other one being short-term furloughed or laid off employees who lost their income. So my question is not really related to research, but I'm wondering, so are you aware of any available data so currently that can point us to that direction? For instance, for senior community, I saw a report on WSJ yesterday saying there are thousands of senior facilities are being impacted within US. Are you aware of any public data source that we can leverage from that perspective, saying say on a county level or on facility level, what's the real-time situation there, confirmed cases, death, etc. On the other hand, for the furloughed employee, is there like a public database, along those lines, say what bigger employers are announcing furlough, and who are they, where they located, etc.
I mean, I do not know about
That's okay. That's
data
okay.
sources. I don't know if anyone else here does or has worked with them, but
That's okay. Thank you.
yeah. I'm going to stop sharing my screen if I can figure out how to do that, because I don't think it's really adding anything. Yeah, I don't know if anyone else has any sort of questions or comments. I know we're getting to the end of the time here, but I really appreciate you all coming and talking about this. I think the more that we can have these kinds of conversations between infectious disease epidemiologists and social epidemiologists, but also between each other, no matter where we are in that in this field, I think the more helpful, as Dr. Krieger said. So thanks everyone for joining us.